Good afternoon, everyone. Thank you for your patience. We're going to start off with prayers first, and then we're going to proceed. So we will have Mrs. Ariste, to lead us in prayers.
Catholic, please sign yourself in the name of the Father, the Son, and the Holy Spirit. Amen. Heavenly Father, we want to thank you. We want to thank you today, Father, for the many blessings you have given to us. And this is one of them. Thank you, Father, for the organizers. Thank you, fathers, for the doctors that are here to enlighten us. Thank you, Father, for all the things you have given to us, which is the breath of life, because without that, we will not be here. Thank you, Father, for all of the persons who are gathered here today. And Father, we ask that you protect them on their way home. We ask, Father, that this proceeding will benefit every one of us that is present here. And we will learn something, Father. We will share something with our families, with our friends, our co-workers. Father, we ask that you enlighten us, help us to focus, help us to be patient in whatever that's going to be happening here. And we ask, Father, that you protect us, you guide us, and you nourish us. In your precious name we pray. Amen.
Thank you, Mrs. Ariste. Okay, so our esteemed guest speaker, Dr. Isla Block, Dr. Mooney, Medical Director of St. Jude's Hospital, Dr. Owen Gabriel, our own oncologist on island, other doctors, nurses, staff members, ladies and gentlemen, welcome. As you know, cancer is one that is sore, and it is very, let me see how I would put that. As a breast cancer survivor, it is a very touching topic for me. It is one where I feel that we need to be educated about it. We need to know about early detection, because early detection saves lives. Okay? I am here today because of early detection. Sometimes we are afraid. We are afraid to go to see our doctors. And sometimes we self-diagnose. We tell ourselves, okay, this is what we have, or this is what we have. Let us try to move away from this, okay? Educate ourselves and do not be afraid to go to the doctor. One thing about me, I'm not afraid to go to the doctor. The slightest thing I have, even if I go to the doctor in tears, Dr. Gabriel will tell you that, and cry and cry and cry, but I will go to the doctor, okay? Today, Sunday was National Cancer Survivors Day, and it is fitting for us to have Dr. Block coming all the way from the US to come and educate us, to inform us. And he's willing and ready to work with St. Lucia to help us here. Okay, to start off, we have a cancer survivor. We're supposed to have 3 persons. Unfortunately, one, her brother passed away tragically this afternoon, so she won't be able to be here with us. However, we have, what's your name? Miss Charlene, okay? So she's going to come and share some of her experience with us.
Good afternoon. Okay, it was, well, I wanted to show the photos. I don't know if the guys will do, but later on, I had a lump right here, and then they told me it was stress. Then when I went to another doctor, I was told that my salivary gland was blocked. I had to eat a lot of sour things, so I was doing that. So after that, May of 2003, I went to the States, and then I happened to go and see doctor because I had a lot of pain. And then they told me the same thing, go and eat sour stuff, and my saliva, I wasn't making enough saliva and stuff. So I left, I went back home, and November of 2023, I went back, and it had grown. It was there like piece of growing flesh or something. So when I got to the friend's house, I had covered it. So when I uncover, I tell her, look what I have. Then it started bleeding. So she told me we need to go to the emergency room, and that's when I went. And then they did a biopsy, and they told me it was stage 4 B-cell lymphoma cancer. And then I had to start chemotherapy. It took over my whole face. But when you see the photos, you'll understand what I'm saying. And then there's a treatment called Our Crop. I did that from December to April. And then I did a PET scan, and then everything was clear. They did a bone marrow just to make sure it didn't spread from my bones. And today I am here cancer-free. My mouth was on the side, my eyes couldn't close. It was painful, 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 but I survived, and I am still here going strong. My mouth, the doctors didn't know if it was going to, they call it paralysis, and they didn't know it was going to go back, but if you also, when you all see the photos, you always see. I am doing good, trust me. It's a big, the scar, you could barely see the scar. A lot of people thought I did surgery, but I didn't do surgery. I did the chemotherapy, and then that's what healed me, and I'm here today. Yes.
Thank you, Miss Charlene Cadet. Okay, so now we're going to hear a little about the Pura Vida Holistic Foundation. So we have Kajana Malcolm, who will share a little about the foundation with you. And the rest of the crew.
Thank you. So we wanted to thank you guys for coming to our first event. We wanted to tell you guys a little bit about the foundation that we started. Pura Vida, as you know, the meaning is true life. It's a family-founded foundation. It's a nonprofit which we started. We established the foundation to help with the welfare and the protection of vulnerable people in the South. As you guys probably know, we're familiar faces, the Malcolms. We've been in the South forever, so we just wanted to do something to assist with our community. So you might be asking, what are vulnerable populations? Vulnerable populations are any high risk, poor, with physical, psychological, or social health communities experiencing economic hardships or limitations such as illnesses and disabilities. So we didn't want to have it specific to just cancer survivors, but as you know, cancer is something that's been impacting our community as of late. In 2024, we had 350 deaths reported in relation to cancer on island. And so for us, it was very important that our first seminar or our first event be something related to cancer. So as you guys are aware, the goal of the evening is just to educate you guys. We hope something resonate with you, whether you're a survivor, whether you're a family member of a survivor, or someone who's currently battling cancer. We hope that you take away something, or whether you're a physician working with individuals with cancer. We hope that you can take something away from Dr. Block, that can help you with treating and aiding your patients. And again, we wanted to thank you guys. Be on the lookout for future events. We will be having things in the future. And as we, grow, we hope that you guys are able to, be participants, whether it's via donations or whether that's via just physically attending the events that we plan to come on. But we want to thank you for coming to the first event, and we hope that you continue to be familiar faces. Thank you.
Thank you, guys. Okay, we're moving right along. We now invite Dr. Owen Gabriel, who is our oncologist on island, to do the introduction for the guest speaker.
Good afternoon, everybody. As has been said earlier, I'm Dr. Owen Gabriel. I'm a practicing oncologist here in St. Lucia, right here in St. Lucia. Although, like the majority of you, I'm meeting Dr. Block for the first time, that has posed no impediment to introducing him. Dr. Block's reputation precedes him. He's well known in the academic field, especially for his contributions to oncology and hematology in New York. And his collaborations with well-known authors and researchers in the field of hematology, lymphoma, leukemias, and so on. So I'm very happy. For me, it's an immense pleasure, and it's a great privilege for me to introduce Dr. Ayala Block. Dr. Ayala Block takes enormous pride in running his successful practice in the heart of Brooklyn. Situated just across from Mount Sinai Brooklyn Hospital, the practice boasts a very convenient location and highest possible quality care. Dr. Block personally devotes a considerable amount of time both obtaining a detailed medical history as well as counseling his patients regarding their treatment options. All office and hospital patients are personally seen by Dr. Block. Chemotherapy is given in the state-of-the-art Hematology Oncology Associates of Brooklyn and Maimonides Cancer Center. Dedicated and compassionate chemotherapy nurses help patients get through their treatments. Dr. Block grew up in Bayview houses of Carnegie. He is proud to have attended the New York City public schools. He attended Brooklyn College, where he earned his BA in political science and received the Anna Berkowitz Memorial Award for Political Science Chairman. He considered a career in law and government, but ultimately and thankfully chose medicine as his calling and attended State University of New York, downstate in Brooklyn. Dr. Block did his residency in Long Island Jewish Hospital and fellowship at State University in New York, Stony Brook. Throughout his training, Dr. Block has had the privilege of working alongside some of the world's most notable hematologists, oncologists. While at Long Island Jewish Hospital, Dr. Block worked with the great Dr. Kanti Rai, who founded the Rai criteria for chronic lymphocytic leukemia, and recently served as the president of the American Society of Hematology. Dr. Block traveled to the Royal Marsden in London, where he worked with Professor Daniel Kavotsky, head of leukemia research in the UK and one of Europe's most renowned oncologists. Rotating through St. Vincent's Hospital in Manhattan, Dr. Block worked with Dr. John MacDonald, who had developed the popular MacDonald regimen for gastric cancer, and Dr. Sundar Jagannath, who has been a national leader in myeloma research. Dr. Block also spent time at Lady of Mercy Hospital with Drs. Peter Wernick and Dr. Janice Dutcher. Dr. Wernick has authored hundreds of publications in leukemia lymphoma, is an editor of the journal Medical Oncology, and is one of the senior editors of an oncology textbook. Dr. Dutcher is a national leader in kidney cancer research. Dr. Block has taken an interest in the psychological and social aspects of oncology care, and received training in those areas on several occasions at Sloan Kettering Cancer Center. Believe you me, if you think we are finished, as the song says, we have only just begun. So Dr. Bloch has been affiliated with many hospitals, including the Mount Sinai Brooklyn Hospital. He runs a private practice exclusive to oncology and hematology since 2009, and this continues today. He's associated with Brookdale Hospital, the New York Community Hospital, the Methodist Hospital, Lutheran Hospitals, Maimonides Medical Center, and South Nassau Community Hospitals. I wanted to also read that Dr. Bloch's certifications include internal medicine from 2003, medical oncology from 2006, hematology from 2007, and also hospice and palliative care since 2018. Many of which things that we need in St. Lucia. He has done a number of research collaborations in various areas of oncology and hematology. As I had said, of his medical education, we know about that, and there are a number of publications in all areas as well. So I'm happy to also say that Dr. Bloch is a member of the American Society of Hematology, the American Society of Clinical Oncology, the American Association of Hospice and Palliative Care Medicine. So I'm very pleased that we have the honor of listening to Dr. Bloch at today's ceremony. Dr. Bloch.
Thank you very much for the warm welcome, and I appreciate being able to talk to you guys. And with that, I'm going to actually get to the slides here. So I recognize that there may be different members in the audience of different backgrounds. So I decided to, in general, talk about cancer screening first. And then, if time permits, maybe we could do something a little more to the health professionals. Something that I really enjoy using and teaching about, which is circulating tumor DNA. It's the ability to detect cancer at a molecular level, not based on CAT scans and blood tests. It's something very new, but I've been using it for already a number of years, and I lecture about it to other doctors and surgeons, and it's really something that I wish could be used more of in general. So let's talk about cancer screening, what we need to know. Well, first of all, early detection can save your life, right? The sooner you discover cancer, the sooner you start treating it, the sooner you get it out, and you're more likely to survive. Now, we need to know that many cancers can be treated more easily when it's caught early, right? The earlier the cancer, usually the smaller the cancer. You let it go untreated, it'll start growing. That's the definition of cancer. Cancer cells keep growing. There's no stop signals telling it to stop growing. That's what cancer is. And we're going to talk about some of the more important screenings that we have in oncology. So what is cancer screening? Screening looks for signs of cancer before symptoms appear. Because it's not about diagnosis, it's about early warning. These screening tests are typically simple tests that we could use. Why screen for cancer? Well, if you find it early, it's easier to treat. You want to prevent the cancer by finding and removing precancerous lesions. And the main thing is you want to reduce the risk of dying from cancer. Now, we're going to talk about a couple of different cancers. The top 5 cancers with proven screening tests are going to be breast, colon, cervical, lung, and prostate. Now, breast cancer screening. What's the test? Well, it's a mammogram. What is a mammogram? It's basically a special type of X-ray for the breast. Who needs to be screened for mammograms? It's women aged 40 to 74. When? About every 1 or 2 years. Why? Because you want to be able to detect tumors before you actually feel them or before they grow larger and larger. Now, what about some extra tips? Well, know your family history, right? History is very, very important. Some cancer families are extensive. A lot of women have breast cancer, so it's very important to know your risk. Also, genetics. You can actually test for some genetic risk factors, like BRCA, or called BRCA. There's BRCA1 and BRCA2. People who have it have a high risk of not only breast cancer, but other types of cancers. And self-awareness, well, you should really also be aware of your own breasts and be able to check for lumps at least once a month. What about colon? Well, here we talk about patients when they have blood in the stool, right? That could be a sign of a colon cancer. A change in bowel habits. Sometimes patients say they have new onset of constipation and new onset of trouble having the bowels go through. Weight loss. Weight loss is always a concern in terms of cancer because a lot of cancer patients lose weight. And even without symptoms, if you screen, you could save a life. So in terms of the tests for colon cancer, we have colonoscopy, and broadly speaking, we have stool tests. Who should be treated? Well, pretty much adults 45 to 75. It used to be 50 to 75, but over the last 20 years in practice, we've been finding more and more young people with colon cancer. In fact, a lot of cancers in younger patients. We've had patients with breast cancer in their 20s and 30s, colon cancer in their 20s, 30s. So we used to think of it as an older problem, but it's not. Young people get cancer as well. Even cancer is traditionally seen in older patients. So when do we do the colonoscopy? Every 10 years, or a stool sample every 1 to 3 years. And why? Because we want to detect and remove polyps before they become cancer or before they grow further. So let's talk about colonoscopy. Well, colonoscopy is actually a visualization of the entire colon. We could remove polyps that are suspicious, but it requires a special preparation, requires sedation. It's a very, very involved technique. And it's done every 10 years if the colonoscopy has been normal. And it's the gold standard for prevention and detection. Well, what are the other tests that we use besides colonoscopy? Well, we have the good old-fashioned stool guaiac. That's been around forever. It's cheap and it's widely available. We also have other stool studies called FIT, F-I-T. That's fecal immunochemical test. And we have a Cologuard test, which is similar to FIT, but even more advanced. And these are stool specimen tests. So let's talk about the guaiac first. That's an old test, as I said, and part of the lecture involves repetition. It's actually a teaching tool. The more I repeat certain things, the more hopefully people will remember them. So it's an old test. It's in the stool. It's based on a chemical reaction. Requires a couple of days of watching your diet. You have to avoid certain meats, certain fruits, certain vegetables. You want to avoid vitamin C. And you typically have to do it every year. So it's a cheap test that's done frequently. But if it's positive, that means there could be blood, there could be colon cancer. You have to follow up with a colonoscopy. Again, that's the only way to actually get the cancer diagnosed, because you need a biopsy. And that's why you need a colonoscopy. Now, I mentioned FIT, F-I-T, and that's maybe a new term for a lot of folks. So again, it stands for fecal immunochemical test. What it is it's still looking for blood in the stool, just like the guaiac, but it's using certain antibodies to that blood. It's a more advanced test. It doesn't require any kind of dietary restrictions. It could still be done at home. It's like a guaiac, it's just a little more advanced. But again, a positive test means you could have blood, you may have to have a colonoscopy. You will have to have a colonoscopy. And now in the other test is a Cologuard. Remember I said Cologuard is a little more advanced than a FIT. There we're looking for blood, but also abnormal DNA in the stool. So it's a more advanced test than even the regular FIT. And again, no bowel prep. You could do it at home, and it's more sensitive. But you can't pick up too much, and so you can have something called false positives, where it's positive, but you really do not have any problem, because it's a very sensitive test. And again, like all the other stool tests, if it's positive, you have to follow up with a colonoscopy, because you have to get an actual biopsy and maybe remove the polyp. And this is a summary, basically, of all the tests for the colon. We have the guaiac, the FIT, the Cologuard, and then going in order of more and more advanced technical testing, finally the gold standard, the colonoscopy, where the doctor has to give you sedation, the bowel prep, more invasive tests, but that's the test that actually could not only diagnose the cancer, but also remove it. Well, let's move to cervical cancer. And cervical cancer screening. So what is the test for that? Well, we have pap smears and we have HPV testing. So who needs to be tested? Women aged 21 to 65. When? Every 3 years for the pap smear, or if you combine it with the HPV testing, every 5 years. Why? Because you want to find changes in the patient before they become cancer. So when to start testing? Well, young women aged 21 to 29 should have a pap smear test alone. Just a pap smear every 3 years. At age 30, you start HPV testing. HPV stands for human papilloma virus. It's a special virus that people could catch that predisposes to cervical cancer. If you do the HPV testing, you do it every 5 years. If you combine it with a PAP, it's still every 5 years. Now you may ask, well, why don't we test for that virus from the beginning? Why don't we just test all young people in their 20s for the HPV virus? Well, the answer is because before the age of 30, it's common sometimes to get these infections and they're transient, meaning they come and they go. So it may not be really relevant to the patient's health. It's more relevant if you find it later in life. What about vaccinations? Maybe we could prevent the virus from taking on and being able to get it. Well, yes, that's the new thing in public health. They've been really recommending HPV vaccinations for all children, starting at the age of 11 to 12. And if you don't get it, you can get a catch-up immunization later on. In fact, people could even get this immunization at the age of 27 to 45, but you have to really discuss with your doctor the risks and the benefits. And the HPV vaccination is important because it prevents HPV transmission and potentially could prevent cervical cancer, anal cancer, throat cancer, and other types of cancers that are related to this virus. It's a virus that could cause these cancers. You get 2 doses before the age of 15. You get 3 doses after the age of 15. So this is very important for public health. And so extra tips with cervical cancer, basically HPV vaccination can prevent most cervical cancers. Now, do not skip screening even if vaccinated. Now, why would that be? Why would you, if you get vaccinated, then you're good, right? Then you don't need to see a doctor anymore. Not true. Because the HPV vaccination is against the most common strains of the virus, but it doesn't cover all the viruses. And so it's not 100%. You could still get cancer despite getting the vaccination. So if you get the vaccination, it's still very, very important to follow with your doctor and get all your usual screenings for cervical cancer. Let's move on to lung cancer. Again, this is just the common cancers and screenings. So with lung cancer, we actually have a screening now tool for it. And this is over the last few years, it evolved with all the clinical trials. And it's a low-dose CAT scan. Who could get this CAT scan? It's people who are the age of 50 to 80 with a strong smoking history. You have to have 20 pack years of smoking. Pretty much 1 pack a day, it's going to be for 20 years. 2 packs a day for 10 years. 20 pack year smoking history between 50 and 80. And how do you do this? You check the CAT scan once a year until they hit 80. And why? As again with all cancers, you find the cancer early, that's the opportunity for potentially for cure. You wait and it keeps growing because all cancer grows. Again, cancer doesn't stop growing. That's what by definition cancer is. The cells that do not know when to stop. They keep growing and growing indefinitely. So if you wait too long, it spreads and then you can't cure the patient. Now, who should not get testing, right? That's an important question, relevant. Well, based on the trials and based on the data, if you quit smoking more than 15 years ago from today, they say no, you don't need to be tested. Or if you have a lot of serious health conditions where even finding a cancer it's not going to help much, doesn't make sense to test. You really want to screen high-risk groups, patients with a 20-pack year history of smoking and patients 50 to 80. Now, moving on to prostate. So we're going to be covering equally, right? Men and women, right? So here, prostate cancer. The blood test is called PSA. And it's a little controversial in the last couple of years about testing for PSA. But in general, who do we test? Men age 50 to 70. When do we test? Every 1 to 2 years. And why? Again, you want to catch the prostate cancer early. Now, more facts. Well, screening is a personal decision. Not all prostate cancers are dangerous. Now, that's an important point because prostate cancer grows very, very slowly. And in fact, there are patients we diagnose with prostate cancer and we leave them alone. We actually, it's kind of difficult to say, but we tell the patient they have cancer and we don't do anything about it. We just observe them and follow them and continue doing biopsies to see if it's getting worse. So not all cancer is destined to kill you. In fact, there are studies where patients who had died and they tested for prostate, and a lot of patients have prostate cancer and never even knew about it and died of something else. So there's some controversy involved, and it's always a good idea to talk to your doctor. But my personal opinion is it's a simple test and it's good to know. And now that they've really started testing less and less because of the controversy, they found more and more patients presenting with more advanced disease because of that. And so I think that's a shame. I think it's a simple test that could be done. And what about other cancers? Well, we live in a very hot island with a lot of sun, right? So skin cancer, it's very important to check your skin, look for any irregularities in moles, changes in the mole, growing moles that are growing, and see a dermatologist, a skin doctor. Liver cancer, people with hepatitis, who have other types of liver disease, they're at risk for liver cancer, also very important to speak to their doctors, but they're really not that great screenings for those patients. And ovarian and pancreatic, again, not really very reliable screening. Not like the test that I mentioned before for those cancers I mentioned before. So, screening versus symptoms. So, screening is when you feel well and you try to find the cancer early. Symptom, usually, but not always, means that the cancer is going to be more advanced. So, screening is the best chance at cure, and it's very important for us to try to get as much screening as we can. And then towards the end of my talk, just to kind of conclude, I mean, smoking, everybody knows by now, smoking is bad and it causes a lot of cancers. The esophagus, bladder, lung. It's not just lung, it's other cancers that are predisposed when you smoke. Healthy diet, fruits, vegetables, fiber, a lot of the processed foods, a lot of the red meats, smoked food, food with nitrites. These are things that are really predisposed to cancer. And physical activity, actually very important. Even patients who are diagnosed with cancer, they found that patients with more regular physical activity tended to live longer. And alcohol also associated with a lot of cancers. And we talked about the skin and just using sunscreen. Just using sunscreen when you're out in the sun, especially 10 to 3, 10 to 2, the worst type of the sun, really is best to just avoid it or put sunscreen. And vaccines, we talked about the HPV vaccine, could prevent cervical cancer, throat cancer, other cancers. Hepatitis B vaccine, which we didn't talk about, but could protect against liver cancer. In general, vaccination will help with cancer prevention. And really important to talk to your doctor, talk to your medical doctor, primary care doctor. Ask them, hey, when should I get my screenings? When should I start? What screenings am I qualified for? What are the risks and benefits of these screenings? But as I showed you through the slides, there's a bunch of very, very common cancers. And we have very specific regulations in the US who should be treated and who should be screened, that is. So take-home message, screening saves lives. Start screening at the recommended ages, talk to your doctor, and really staying healthy is staying informed, and that's what's great about this foundation and sponsoring this talk, is to have everyone more informed. And here's a summary, again, repetitious, but here's a summary of everything I talked about. The common cancers: breast, colon, cervical, lung, and prostate. The populations that need to be screened, the actual screening test that we use. For breast, it's the mammogram, and for colon, it's the colonoscopy. For prostate, it's the PSA. For lung, it's the CAT scan. And the ages, and again, there's typically a shift towards younger and younger ages with time. With colon, we're starting at 45. You need a colonoscopy now in general at the age of only 45 now, as opposed to 50. And that's it in terms of cancer screenings. And then I wanted to move on to something called circulating tumor DNA. Just need to look at the other slides. We're going to talk about that in brief. No, same thing. Just going to max it out. And let me Signaterra. Yeah. Okay, so I want to really talk about, let me get this on the screen. So circulating tumor DNA is something I'm very, very excited about. It's something I lecture a lot to doctors, and it's a technology I think that's, doesn't come up yet, that hasn't really still been used as often as it should be. So, you want to minus it out? Oh, yes. Okay. How do we get that thing to come off? That right there at the corner. Oh, there it is. Yeah, good. Okay. So the company that I specifically talk about is called Natera. And they are a big, big leader in something called circulating tumor DNA. And to put in layman's terms, basically it's our DNA that we're testing for. And sometimes it's the DNA of the actual cancer we're testing for in the blood. So this technology has actually been used in many, many, many patients in other fields, not just cancer. So pregnancy, right? Very, very important. So the test is called Panorama. So pregnant women get a test called Panorama looking for any evidence of birth defects. And what they do is they look at the blood and they look for DNA of the fetus in the blood. And that could be a sign potentially of a birth defect. On the right, organ transplantation, very, very also widely used in the US. So patients who get a kidney transplant, they're able to test their blood for the donor's DNA, and that could be a sign that they're rejecting their transplant. So very, very interesting technology by doing a blood test and being able to detect birth defects in any pregnant woman and transplant rejection in patients who have renal transplant. Now, what I'm interested is in the oncology part, in the cancer part, using circulating tumor DNA in the blood to help us manage our patients. So on the bottom of this slide, you can see there's a whole continuum of uses of this circulating tumor DNA. We could actually use it in patients who have no cancer. Remember, we just had a lecture on cancer screenings, right? And picking up patients who may have cancer that don't know about it. Well, we could actually pick up cancer in patients who don't know about it by looking for abnormal DNA in the blood. And we have companies called Grail in the US that specialize in that. And unfortunately, they only take cash, and basically the patients get a blood test, and they're able to look for abnormal DNA in the blood. And that could be indicative potentially that they have some kind of cancer. To the right, all it's right, it's cancer therapy selection. This is patients who already have cancer. They have widespread cancer, and we could do a blood test, and we could actually look for all kinds of changes in the cancer, and then gear our treatments, target our treatments against those specific abnormalities in the cancer. And there are companies that specialize in that. Caris and Tempus, and even this company has a specific test for that as well. But I like to focus the middle ground. And the middle ground involves patients with those three characteristics. Being able to look for evidence of minimal or molecular residual disease. So patients have cancer, right? They have surgery for the cancer. They remove the cancer. And right after surgery, the question is, do they still have evidence of cancer still in their body that we don't know about, like little cells that we can't see on CAT scans or any kind of imaging? Because if they do, remember what I said in the beginning of the lecture? Cancer keeps growing. There's no stop signal. So that little 1 cell or 2 cells become 4 and 8 and 12 and keeps growing. And eventually, it could be in a year or 5 years or 10 years, whenever it is, but eventually they will get advanced cancer. So that minimal residual disease is being able to pick up that cancer at the most minimum level, at the level of their DNA. Now, the second part is surveillance for early recurrence. So a patient had the cancer, had it removed, and it's long gone, we think, and now we're just monitoring them. We're just monitoring them for the next couple of years. Again, looking at the blood tests and looking for the genetic changes in the blood to tell us maybe they have some cancer cells that we don't know of that are slowly growing, silently growing, basically. And finally, the third type of use of this technology is treating and monitoring treatment responses. So there, unfortunately, the cancer has already finally spread, it's grown, but we could still monitor that cancer at a molecular level, at the blood test level, and see are they responding to treatment or not responding to treatment. Sometimes CAT scans are not helpful. PET scans may not be helpful. Sometimes it takes a while to show up on these tests. So we could monitor the patient on a molecular level. And the way the test is done, it's a little bit blurry here, the way it's coming out on the projector. But basically what we do is we test the actual cancer itself. Like we know the patient has cancer or had cancer, we go back to the original biopsy or back to the original surgery when they removed it. And we take a piece of that cancer and we analyze it for all these abnormalities, all these genetic abnormalities. Then we draw the patient's blood and we look for those abnormalities in the patient's blood. So that's how we know what we're looking for, because we test the cancer either while they had it or when they already removed it from the pathologist's office, and we test it and we see the signature of the cancer and we look for that signature in the patient's blood. So what we really want is a test that we could really look at the lowest minute level, and that's what this test is. It's a personalized tumor-informed test. We're able to look at the level of the DNA. We're able to remove sources that could give us false results, false positives that they call it, meaning results that are positive but they're not really positive. And we manage to account for that by certain testing that's done. And we measure this on a molecular level, as I said, called mean tumor molecule per ml. And we track this cancer over time. And there's actually a whole bunch of studies that are supporting this technology. This is actually an old slide. Right now it's probably triple the amount of studies, and it keeps growing and growing. The original cancer is colon, and then I'll show you some data for the other ones as well. In fact, here they are. So these are the 4 original cancers. Again, colon was the first, but then there was data in breast, lung, and bladder. And what it's showing is patients who have the positive DNA, it's called circulating tumor DNA, they are in the blue. They have much worse survival than if they're negative in the sort of here it's green, but in the lighter color. When they're negative, you see they live much, much longer. And if you detect cancer from the blood on the DNA level, the patients do a lot worse. And the way the test is reported, it's also a little faded here. But basically, they're telling you if you have evidence of cancer or not. It's a qualitative test, and it's a quantitative test. It tells you, it gives you a measurement of the amount of molecular levels of cancer that it detects. And through time, it tells you if there's any change, right? If the cancer is getting worse or better, simply from the blood test, looking at your DNA, looking at the DNA in your blood. And in the US, it actually got approved for colon cancer, for patients on immune therapy, and also now for bladder and for lung treatments as well. So it's really a great technology, and the way it's done, and I actually don't necessarily follow it exactly, but this is the regimen, how it's drawn. The main thing is you gotta draw a specimen around 3 to 4 weeks after surgery. Why do you have to wait? Because surgery, a lot of inflammation in the body. After surgery, it's gonna throw off the test. So you have the surgery, you wait a few weeks, it depends how big the surgery is, whatever cancer someone has, and then you do this test. And then I just monitor every 3 months. And that's how we monitor the patients at a molecular level, at a DNA level, to see if they have cancer or they don't, to see if the cancer is getting worse or better if we're treating it already. And so you need a certain amount of tissue, and then they draw a blood test. And they draw 2 vials. When we're monitoring our patients, the doctor has to just draw 2 vials on you every 3 months. And they look for the evidence of DNA from those 2 tubes. And basically, just to run through, the main studies were in colon cancer. And they found, and this is very interesting, because remember, we just talked, this actually nicely follows from the lecture on screenings, in that when they did the test, they found that using this DNA, it was much more powerful than any of the typical tests we normally do traditionally. For example, it's not here, later on the slides, we check what they call a CEA for colon cancer. This test is much better, because looking at it molecular level. So it's better than how aggressive the tumor looks under the microscope, what stage they are. Looking for evidence of cancer in the blood is much more helpful to know whether the cancer is going to come back or not. Much, much more helpful. And these are tests where they measured against our typical test that we use in oncology called CA. Maybe folks have heard of it. It's anyone with colon cancer, the doctor is always checking CA levels, right? So checking at the DNA level, much, much better to pick up evidence of cancer or to rule it out than the traditional CA. And you don't see the arrows on the projector here, but what it's showing, this is also very interesting. When they analyzed the data, they found that sometimes you could pick up cancer up to 16.5 months previous to any imaging study. In other words, you know how we do CAT scans looking for cancer, and then we see if there's evidence of cancer on the CAT scan or not? Well, this test could find evidence of cancer more than a year prior to any CAT scan, because it's looking at a molecular level in the blood, at the DNA level. So that's how powerful this test is. But that's the maximum. The average is 8 months. But still, 8 months, you could detect the cancer 8 months earlier from this blood test than when you're getting your CAT scan. And we think of CAT scans as a pretty good test, right? Looking at inside your body at everything that's going on. This blood test is much more powerful. And then they did more data. I'm just going to run through it quickly, but basically they did more studies in colon, and they confirmed exactly the same thing. And the other thing which is important is we talked about picking up cancer, right? But what about the other flip side of the story? What about being able to rule it out and reassure a patient that the cancer will not come back, right? What about on that point? Well, what they found is when you do this test multiple times and you're getting negative results multiple times, it becomes much more powerful. So if you have 3 negative results, the chances of the cancer coming back is almost none. I mean, basically 97% of the patients, the cancer did not come back when they had 3 negative results on this blood test. So this test really is able to rule out the fact that the cancer will come back. But most of the data is in colon cancer. And this also, again, here you could see it well. So when you go up on that axis, we see 0, 10, 20, 30, that's time, right? So you could see to the right, you could be able to find evidence of cancer. That's called the ctDNA, circulating tumor DNA. And most of these are sloping upwards, and to the left is CAT scan. So you're first picking up on the molecular level at the DNA level, and then eventually, as time goes by, you're picking it up on CAT scans. And this is kind of summarizing the data from the trial, showing that they're able to pick up evidence of cancer about 8 months before CAT scans. And so this is just one clinical trial called Bespoke, but basically it's deciding whether to use this data, to use this circulating tumor DNA to make decisions. A patient needs chemo, doesn't need chemo. There's a lot of studies about this, or to give more intense chemo, less intense chemo. But that's the technology I wanted to introduce to the audience, and also that there's health providers here in the audience, so I figured it'd be kind of interesting information. And those are the 2 lectures that I'm giving today. Okay. Oh, yes, that's the point. Thank you very much. Yes. So does anyone have any information on any questions about any of what I talked about, especially the ctDNA, because that's new. I mean, to my surprise, even in the U.S., a lot of doctors have been very slow. They're not using it at all. And it's like taking so much time to get them to use it, but it's really, really helpful. I mean, I use it, I have a lot of experience with it because I've been using it for over 5 years, and probably hundreds and hundreds of patients. And there have been patients where, certain cancers we treat aggressively before surgery, right? We talk about surgery, but some cancers, we first give chemo first, radiation first, to try to shrink it, and then take them to surgery. And I've used this test, and I was able to see that there are some patients where there was no evidence of cancer after chemo and radiation, and we did a CAT scan, and it was clean. And then the question was, should we go in and do this major surgery on them, both from above for patients with esophageal cancer, and also from below, patients with rectal cancer. The up and bottom part of our stomach system, our GI tract, we kind of treat them similar. We give chemo radiations often to shrink it. And so I had patients both from above and below where this test was originally positive when they had cancer, and when they got intense treatment, it became 0. And there were times when the surgeons, believe it or not, said that they didn't want to operate on the patient because everything was 0, and we decided just to observe the patient. And this one police officer I have as a patient, he had rectal cancer, he had chemo radiation, negative CAT scans, negative circulating tumor DNA. His cancer never came back. I've been checking it, and all his DNA tests have been negative. It's been 3-4 years and no cancer. So it's really helpful in some cancers, not for every cancer. Some cancers it's not reliable, but definitely colon, but also it's being used for bladder, lung, and there's also other cancers, ovarian cancer, they're looking at it, and ovarian cancer as well. So I think it's very helpful. So it's something new, it's expensive. The companies, has arrangements in the U.S. where the patients aren't, charged for it, but that's really what's going on in the U.S. in terms of this technology. I think it's very, very exciting, and I wish it could be used more often everywhere in the world.
You made mention about the lung cancer.
Mm-hmm.
You said persons who are smoking for X amount of years, they should take the person. But what about those persons that are being around the smokers? They are
Yeah.
not smoking, but they are at risk also.
Yeah, so that's not, yeah.
How, whether at what point should we
That's a very, very good question. I have to go back to the slide, but basically, the data is just specifically with smokers, at least in terms of insurance approvals, because like in the US, we have to submit it to the insurance, they have to approve it, and so you have to fit the criteria to allow them to pay, otherwise they're not going to pay for the CAT scan. But to answer your question, 100%, non-smokers that are exposed to secondhand smoke, I mean, I think I'm exposed because I have a good nose for smoke, and I could smell it a mile away. And I think I'm exposed almost 24, I smell it all. I have windows open in my office, people walking along the street, and they're smoking, or the nurses or doctors taking lunch breaks from the hospital, standing around the corner smoking. I smell it all day long, and I'm very angry. And basically, you're at risk. Yeah, it puts you at risk for all the smoking-related cancers.
Should you take the, at what point should you take the
Yeah,
test?
that's a really very good question. Unfortunately, the best answer is if you don't fit the criteria for the approval, the insurance may not necessarily cover for it. That's the problem. Yeah, but that's a great question. I mean, I wish you could, yeah, because I think you're just you're just at risk, especially if you live with a smoker. They're smoking, you're smoking. That's the problem. Secondhand smoke. I don't know what the policy in St. Lucia is like on the beach. Are you allowed to smoke? Are you allowed to? That's great. No smoking? That's very good. That's very, very good. That's very good.
How many different tests are there for the prostate?
I mean, the main one is the PSA, but there's actually companies also that constantly trying to make other tests. I've heard there's a company in England called Biodynamics, I believe, that they had some kind of test for prostate cancer as well. But they market it and sometimes they disappear, and I haven't heard from them again. But there are companies looking for other tests. PSA is the traditional test that we've been using for decades. And the question though is, even if you're positive, what to do with the information. And sometimes you get positive and it leads to a lot of biopsies, and sometimes it could be inflammation in large prostate or prostatitis. And the concern is men getting a lot of biopsies, maybe they don't need it. From my point of view, it could save someone's life. It could detect cancer of the prostate much earlier before it spreads everywhere. And I've been hearing now data as there's all these contradictory trials where they say maybe people shouldn't be tested as much. Overall, they're finding more and more people now coming in the U.S. with metastatic prostate because the field has slowed down in terms of all that PSA testing, right? Less people are tested because of the controversy, and more people end up diagnosed with metastatic prostate. So I personally, feel I test all my patients that I can, and I say if you come back positive, we'll figure out what needs to be done. We'll analyze other data because there's a lot of lab tests that are sort of on the side, but they could help you interpret the results. Like, for example, alkaline phosphatase. It could be elevated in bone involvement. Sometimes patients start getting more anemic. You kind of look at the whole picture and analyze it. So I would say I personally do these tests. I'm a big proponent, and then I say if it's positive, we'll sit down and we'll decide what to do next based on your medical conditions, based on your wants. Some patients don't want anything, right? Based on what your personal preferences are. So it's called basically shared decision making, meaning that it's a decision that is made after consultation with the patient based on my medical opinion, but also based on the patient's preferences.
What time should we be counseled?
Counseled to do the test? Pretty much, midlife, when it matters. I mean, you don't do it, you wouldn't start testing at 90 because at that point your life expectancy is not that much more. So it's really meant that if you find it, to be able to prolong someone's life. you know. And same thing with the other cancers. And even I showed with lung, they said, you know, don't do it after 80, because it's really designed to be found early and to prolong your life, not for people who already are at their life expectancy.
For a layperson here, the doctor do a PSA exam, investigation. At what level? I mean, some of us do see our results, and we know the range is stated. At what level should the layperson start asking questions or be concerned?
So that's also a very, very good question, because, you know, we think of, well, if it's abnormal, then that triggers a worry. But I also look at what the amount was before and what the amount is now. So some with a PSA of 0.5, and now the upper limit loma is 4, and they're 3.5, and that's a huge jump. I want to know why. Do you have, you know, what's going on? Do you have an infection? Is it enlarged? Why is it all of a sudden it leads to questions? So I would say if the increase is dramatic, that's a sign to discuss with the doctor to look into why they think it is. Certainly the numbers that are extremely high with any of these cancers. What I always say, it's not diagnostic of cancer, but it's suggestive. So if any tumor marker is extremely high, in the hundreds, I mean, you have to look further. You can't ignore it. You can't ignore it. So PSA, you know, even above 20, 30, I mean, you have to start thinking that it's probably going to end up being a prostate cancer. And you have to, you know, look into it further. I would not ignore abnormal lab values. But how aggressive to pursue it is shared decision making, and based on the patient's medical situation. I mean, if they're frail and elderly, I probably would never even test them. But, you know, if they have another cancer, if they have heart failure, if they have any other medical problems where, you know, start pursuing this prostate diagnosis just won't make sense, because in general, prostate is very slow growing. It doesn't pay to aggressively pursue it if there's something else that's more imminently dangerous to the patient.
So what really causes prostate
cancer? Yeah. I mean, it's what causes prostate cancer. I mean, it's the most one of the most common cancers in men. It's part of the aging process. I mean, we don't know exactly.
Is it compulsory that men must have prostate?
No, not every man's going to have prostate cancer. But remember what I said, when they did tests on deceased patients, they found a tremendous amount of prostate cancers in the early stage that they never knew they had, and they ended up dying of something else. So chances are, once you live to a very ripe old age, you know, 100, right? Chances are you probably have some element of prostate cancer, you know, at the minimum level, because it's so common, and as you get old, I mean, so many people have it that they don't even know about it. They don't even know about it.
Dr. Blog, good evening. Dr. Blog, and I just want to congratulate you on a beautiful presentation.
Thank you.
Your content was superb, and we are inspiring technology that we have available. I hope and pray that someday in the not too distant future that technology will become available here, so that we will be able to material. You stressed a lot the importance of early detection and prevention, and I just want to let our audience know a few of the services that are available, of course, with your permission. A few of the services that are available directly to what you described in your presentation. So I just want to let the audience know that I think there are a number of the very same procedures that Dr. Blog mentioned that are available too. So for example, for breast cancer is present in the leading cause of cancer death amongst females. At St. Jude's from March 7th this year, we actually launched a number of resources. So you can get your mammograms at you do yourself breast exam, visit your physician, or you can come see a physician in the outpatient clinic and you can get your mammograms done. If anything is detected, you will refer to the surgical clinic and you can get a biopsy. So the surgeons will prefer they can either do a needle biopsy where they take a little bit of the tissue, or they can actually do an excision biopsy where they take off the lump and they test it. That's breast cancer clinic. For colon cancer, we talk about the colonoscopy. Fundamental, because you see a lot increase in gastric, stomach cancers, as well as colon cancers. One of the key tests, like you mentioned, was the colonoscopies, and that you can get from that individual. So again, you come in, you get a referral from the GP, or you come see one of the doctors in the outpatient clinic, and you be referred to the surgical clinic so you can get your colonoscopy scheduled. If during that test the doctor sees anything that looks abnormal, anything that can become cancer later on, then actually take a little piece of it and send it to testing. And right there, you get your early detection and you get your prevention. For prostate here, we're worried about the PSAs. You can get your PSAs done at St. Hospital, we also have a urologist. So if your PSA is very high, you can go to the urologist, you will examine you, do a biopsy if necessary, so that we can detect it. For stomach cancers, we do the endoscopy, which is the second colonoscopy, which is the camera in the bottom, it goes up along the intestine. With the upper GI endoscopy, you go to the mouth. It goes all the way into the stomach, into the small intestine. If there's anything growing, or there be a cancer or something that can become a cancer, you see it, you test it, so right there you get a diagnosis so you can start treating. So all of these services are available at St. Jude. So again, early diagnosis saves lives, so we're all about detection, early diagnosis and prevention. And I cannot help but say that at St. Jude we have all of these there to support you. So see your physician, do your self-exams for the ladies, or your PSA, so that when you see anything abnormal, you can come in.
Back to prostate. You might be asking why as a woman I'm asking about prostate. Earlier you mentioned in the cancer screening, you said persons test are then between 40 and 70. So what about men over 80, number one? And number two, what symptoms would those persons exhibit to enable them to go for the PSA test? And number three, does blood being seen in the urine, is that analog for any problem?
So blood in the urine. So blood in the urine could be microscopic that we don't even see when the doctor just checks your urine for blood. And it could be gross blood that you actually see the blood in the urine. Either way, to me it's always an indication if once I get patients and I see that on their lab results, it's one of those things where I automatically, I see that, I say see a urologist. They have to see a urologist. Why? Because blood in the urine, it could be a stone, it could be something benign, but it could also be a bladder cancer. It could be a kidney cancer. So it needs further investigation. Any blood in the urine pretty much needs further investigation. In terms of prostate age, when you stop, what do you do with someone who's 80? Well, I gave you the guidelines, right? That's designed overall, right, to cover large populations. I usually more aggressive a lot of times because if I have patients that come in and they're coming in and they look great and they're vigorous and they're 80 and they look like they could live until they're 100, there's certain cancers, in my opinion, that sometimes are worth finding out about because the treatments are so simple. Prostate and breast are the two that come to mind the most because both, even if you have advanced disease, for example, a lot of times the treatments are just hormones, not even chemo, just hormones, and they work so well. And for both, if you catch it early, you can just get rid of it completely. So I usually push the envelope a little bit with the age, and I've checked patients a little older than the guidelines because I feel if they're vigorous and they're strong and they could live another couple of decades, I personally feel it's worth testing, but not for every cancer, right? The ones that I feel are easy to get rid of, and the treatments are very simple. And the patients respond very well to those treatments. Those are the cancers that I have usually a little more leeway, and I kind of, want to see if I could find something to help the patient early. In terms of symptoms for prostate cancer, well, that's the whole point of some of these screenings. You want to find evidence before they have symptoms. The typical symptoms of my patients when they have advanced prostate cancer is bone pain, because prostate loves to go to bones. Loves to go to bones. So basically they have bone pain, back pain, and that could be a sign that it's spread to the bones. But they may not have any symptoms. They may have symptoms of an enlarged prostate. I mean, if it's a mass, it's similar to enlarged prostate. They may have trouble getting urine out. But they may have no symptoms if it's relatively early, and they won't know about it.
I noticed you said that the test is, in essence, you're saying that it is sensitive and specific.
Which test? This one, the ctDNA? Oh, yes.
Can it ever be wrong?
Oh, yeah, because it's not 100%. Let me see if I have the data here. Yeah, I mean, it's not 100%. And so it's not 100%, but for example, longitudinal testing, and here to the right, you have ctDNA that's negative. I mean, they have 97% chance that the cancer won't come back, but it's not 100. There's still 3% it could still happen. So it's not the test is not 100%. But the numbers are tremendously better than any other test that we have for some of this stuff.
I have a question. Regarding the ctDNA testing, is it specifically one type of cancer?
So that's a great question, and that leads to really understanding how the test is done, because understanding how the test is done, then you know the limitations, and you know when to do it, when not to do it. So the test is done, on the actual cancer. So it's not a test, at least this specific company and this specific test called Signatera. It's not designed to detect cancer in patients who never had it. It's designed to detect cancer in patients who had it, and to be able to detect the cancer at the earliest molecular level before that cancer spreads. So, and that's why you need the actual cancer material itself to test it. For what we do is we take the actual cancer, whether it's in the patient or whether they already had it removed, and we test it for a molecular signature, for a molecular trademark. And then we do blood tests, and we look for those specific genetic changes in the patient's blood. So you have to have had the cancer originally to use this test. And the whole purpose in general is to be able to detect the cancer early at a molecular level. Either in the beginning to see if they had it or not. So when the oncologist needs to decide, does the patient need chemotherapy or not? Or to try to find evidence that it's come back a year before the CAT scans show evidence, so you could potentially look more carefully. You could maybe do the scans more frequently. Some cancers, if you just catch it early and when it comes back, the surgeon could still remove it again, and it may potentially still be cure, or at least buy you much more time. Because in general with cancer, the more you have it, the harder it is to treat it. Right? So it's nice to be able to catch it early.
What is the feasibility of these tests?
That's a good question. That's up to the company, but I think that's something that it may be potentially a political thing, where if the politicians talk to the company, and it may involve more than just science. It may involve political people talking to the company.
I mean, a lot of what has been said, at the core of the matter, even what Dr. Moore said, cancer care is cost prohibitive.
Yeah.
So the very basic screening interventions A mammogram in St. Lucia costs $150, $200 EC. $250 EC, it's 100 US. So many women do not do their mammograms because they can't afford it. So that's at a very basic level. Genomic sequencing, we have used in St. Lucia since 2020, but it costs 5,000 US
Oh gosh.
to have genomic sequencing done for a patient and sent all the way to India, which is the cheapest one that we have available. So we are able to do ctDNA here, but it's 5,000 US at minimum. Now, most patients who have had a cancer, by the time they get diagnosed and treated, they have lost all, they become bankrupt. So now when I'm looking for recurrence, I can't ask them to do a ctDNA because, all the funds have been exhausted at that time. So for me, the issues here are very clear. The evidence is very clear. The question is, do we have the money and the insurances? And I know universal healthcare is on board, but can we ever get to that point? I don't know.
And I think with time, a lot of these tests hopefully do get cheaper with time. But that because it's a new test, they don't even use it in the U.S. They're not even, a lot of patients don't even, like you go to Sloan Kettering, a lot of times they don't do this. They don't, like my patients that go to Sloan Kettering, they don't do this test a lot of times. They think it's too new and they don't want to do it. So it's not like you're not getting it here. They're not getting it there either. They're not getting there. But it's something I wanted to introduce because it's very fascinating science. In some ways, it shows how much science is changing. And in some ways, it's also for, a reason for optimism if you have cancer, knowing that science is constantly evolving and constantly growing. And so we're getting new treatments and we're getting more diagnostic things available. And just a matter of time, just a matter of time. Okay.
Is there any other way? I know mammogram, a lot of us, including me, are afraid of the mammogram. I think it's fear because they say they squeeze your breast and if you do that cancer, you can get cancer.
Yeah, no. So that's actually a common. I heard that a lot. So I would say that's definitely not true. It won't cause cancer. And I think, remember I said there were two cancers that I'm particularly, passionate about, breast and prostate, because there's such good treatments and such good interventions. And, as most cancers, if you catch it early, you could cure a patient. So I think it's just a tragedy if you don't get the mammogram when you're supposed to. You have to have your mammograms at the specified screenings because it's so helpful. It's so helpful, and why miss something that could be cured? And these things affect, productive women in their prime of their lives. Yeah, you really have to get the mammogram. Okay. Thank you, everybody. Thank you.
Thank you to Dr. Block. I think we all learned a lot. I myself, it was a lot of information for me. As somebody who had cancer, the thoughts and, sometimes the slightest thing that you feel, you are fearful, you are afraid. What if it returns? What happens? It is something that it reoccurs all the time. It comes back. It is very unfortunate that, like Dr. Gabriel was saying, the cost, because let me tell you, going through treatment, going to see the doctor, there are many people who I believe they die because they're not able to pay just to see a doctor. To see a doctor, if you go to a specialist, from $200, $250. Some people don't have that. We don't have that. So it's very costly. I was really hoping that the Minister of Health would have been here for him to hear all of this, because it's needed. We need that. And I am so grateful that Dr. Block was able to come and share this knowledge with us. It's very important. But what do we do? How do we move from here? Okay, 5,000 US, I don't even have 100 US. So how do I get that test? Because I want to know. Let me tell you, I want to know. I always want to know. And it is very important to know. You do not feel well. If you have to ask 100 people to get the funds to go and see the doctor, go to St. Jude's. Dr. Mooney, I don't know what's available if you don't have money. If you come to St. Jude's, I don't know what's available. Okay? But it is important, people. It is very important to get those screening done. I have one breast, and when I found out that I had breast cancer, the doctors, they were like, "You're young, you want to save the breast." I'm like, no, I want the cancer out. I don't want to have cancer. So if it means taking off the breast, take off the breast. Okay? People see me and they're like, when I say I have one breast, really? Yeah, I do. I have one. I didn't have surgery, but I have two, right? Who can tell which one is fake, which one is real? But it's important. Get your screening. Go for your mammogram. I go for my mammogram every year. I do it. Get your pap smears done. I believe nobody should die because of cervical cancer. That's my belief. This is a cancer. I'm not an expert, but it takes time. So if you do your screening, if you go to the doctor, get your pap smear. Some people, they don't want to open their legs for the doctor. It's easier and cheaper for you to open your legs for the doctor than just open, no. So go get your pap smears done. It's important. Get your mammograms done. Whatever test is available. And I do know that at the health centers, they do provide some of the services as well. I'm not an expert, but maybe somebody can share and let you know. But this information, it was critical, it was important. I appreciate it. I am so thankful that he was able to come.
All health centers?
All health centers are here. According to the results, it is either medical doctor. So we have gynecologists, where the call was copy for you, and you do testing, and you further testing. And with the call, depending on whatever, they can do a biopsy, which they have to do the biopsy. But the doctor says the doctor is free, the test is free, and the patient vaccine is also free.
Thank you. So you heard it. Okay?
And for the men, we have the screening for the men for persons. At the People Health Center, every second Saturday of the month, we have the screening for the men for men's health, and we do the PSAs and we do the investigations.
Okay. Thank you.
It's free as well, but you don't have to pay.
Okay. Thank you so much. You want to? We're going to do a presentation to the guest speaker in a little bit to thank him officially. But Miss Charlene, she wants to share some of her pics with you.
Your discretion is advised. It may not be in order, but I will explain. We'll just let it clear and I'll explain some. You let it play from beginning to end. I'll just explain. Huh?
All right.
Okay, that was when I came back after my treatment. That was me. That's when I just went up. That's me at work when the signs started thinging. The one before, that was after chemotherapy. That's how it got within a few days when I arrived in the States. That's after my first session of chemotherapy, that's how it came. When I came and I said it was bleeding, that's what it was. And then it started opening and opening, and it took over my whole face on that side. But I had no surgery, that's why I said it just kept opening. It was very painful. We don't have that here, so I was looking for places overseas where I can do surgery. I don't know if it's me prolonging the process, but it's just getting the place, every place. The amount they was asking was so much that I left it. That was in May, and then when I went up in November, that's when it just burst and then started getting bigger and bigger. So I didn't do any surgery, and the doctors were not sure if everything would go back, so as you could see, everything went back to almost normal, I should say. So I'm very thankful. I was journey on my own, but I survived. You just have to have confidence that everything will be okay, because a lot of us, when we have cancer, we feel we're dying right away. Because when the doctor told me I had cancer, I cried, and then when I realized that, you know, there is a cure, I started building up my confidence. I did everything. I went to chemotherapy. I was just strong about it. I wasn't thinking any negative thing. I was just doing what I have to do. But it was a journey, painful, but I survived. Thank you.
You are very strong, Miss Shirley. Congratulations. Adiela? So we know Dr. Block likes his paintings from St. Lucia, so we're presenting him with a small token of appreciation. Please. And Miss Shalene, we want to present you with a small token also. Thank you. Okay, so we have some other tokens, but before that, we have a special rendition by Mr. James Lewis. James Lewis? Okay.
Hi. Good evening. Doc, thank you very much for the enlightenment on cancer. You as well, Dr. Gabriel and Dr. Mooney. In situations like this, we need to show each other love. And like the great Robert Nesta Marley said, we all need to come together and have one love.
This event would not have been possible if it were not for some key persons, which just want to say thank you. GVD, thank you so much for being with us tonight. The proprietor of this place, Mr. Kenneth Malcolm. St. Jude's Hospital, from the time we contacted them, Dr. Mooney, they were very willing to assist. Blue Waters, Blush, Goddard Catering Group, Sadu and Sons, Cuthbert Malcolm, Maria Ariste, members of the foundation, Mr. James Lewis, and everybody who came to hear, we thank you. Right now, we will have the vote of thanks by Ms. Janelle Malcolm.
Good evening, everyone. First of all, I'd like to thank Dr. Block for making this long journey here. Thank you so much, we really appreciate it. Also, Shallow, for coming along, thank you. And thank you everyone else who played a key part in this, especially my brother, Kajana, my niece, my sister, Delia, Philia, Ms. Daniel, and Mr. Ian. Thank you so much for the lovely decorations and the refreshments. Thank you so much, everyone. Thank you for coming. Have a wonderful night.
Okay, so we have some refreshments outside on the podium. Where? The pool area? Okay, thank you, sorry. So we have some refreshments by the pool area. I'm thinking that Dr. Block would like to speak to our medical professionals here, so you could stick around to, to speak with him. All right? Thank you. Thank you.